this is a Zambian workshop. We've done an energizer by now, so let's just sort of pretend like we've just done an energizer and finish off this last session. I wanted to thank Julio and the organizer for inviting me to share on behalf of Zambia, and I want to especially thank Dr. Albert Mwango from the Ministry of Health, who wasn't scheduled to attend this meeting, for letting me go ahead and present this data. And I want to thank the University of Maryland, since I spent less than 8 weeks there in the last 8 years, for supporting me living and working in Zambia over this period of time. Briefly, I'm just going to go over the POP-ART trial, but in the next session they're going to go into that in more detail, so I'm just going to mention that. I'm going to briefly touch on Zambia TasP evolution and the importance of the community and where we're headed with that strategy, how we're changing paradigms a little bit in our treatment, and the community solutions and some proposal questions. POP-ART is a HBTN 071 study that will be presented the next session, and it's a large 5-year community cluster randomized trial in South Africa and Zambia. It will be measuring the impact of a universal HIV test and treatment intervention at a population level, and will hopefully give us some information on incidence and also some strategies on how to nationalize the treatment as prevention program. This is a slide that was given to me by Sarah Fiddler, who will be presenting in the next session, and I just want to mention on this slide that it'll be 3 arms. They hope to enroll over 50,000 patients in this study with a primary outcome HIV incidence at 36 months. And the part that I want to highlight in relationship to my talk is that the inclusion of what they call community HIV providers, or CHIPs, that are going to be an integral component of linking facilities with the community. The premise in Zambia that we're working for is that the current model of HIV care and treatment in Zambia is probably not sustainable or scalable using the model we're using, and that stopping new HIV infections is really the key to sustainability. Western models of healthcare are really not well suited for an HIV global pandemic or the African culture, and that treatment as prevention can really eliminate new HIV infections. And the premise we're working from is that really initiating care in the community is more cost-effective and efficient than facility-based care. In Zambia, we started thinking and talking about treatment as prevention back as early as 2006, and realized that the first step to that was getting a good first-line therapy. And so tenofovir was introduced in 2006 because it provided the potential for once-daily therapy with minimal side effects and, importantly, predictable resistance patterns. In 2010, there was a lot of discussion, and in 2011, we implemented treatment of discordant couples, recognizing that treatment as prevention was the key to reducing new infections, along with changing the CD4 threshold, treating all patients with TB and hepatitis B. And now we're implementing option B plus starting in that was approved in 2012 and being implemented in 2013, and using option B plus as an opportunity to develop the community infrastructure and models for treatment as prevention that can be expanded as treatment as prevention comes forward. At the highest level, there's a strong commitment to moving forward treatment as prevention in Zambia, with anticipation that maybe by 2014 this will actually become a reality. One thing that was realized in Zambia is that with different epidemics you have to come up with different strategies, and in a Western HIV epidemic is more localized to specific subpopulations, as many of the speakers have pointed out, with lower generalized prevalence, and it is really based on specialized care with variable treatment options and extensive research and laboratory monitoring. Where in sub-Saharan Africa, we're dealing with an epidemic that impacts the general population with a very high prevalence. It's more generalist-based care, and we're more involved with doing safety laboratory and less laboratory monitoring. And so we need to really change the paradigm to have a sustainable and scalable program. The Honorable Dr. Joseph Kasande, the Minister of Health, in an address to Parliament concerning elimination of mother-to-child transmission, stated that we are convinced that active participation of the community in our efforts to improve maternal and child health was the missing link in the attainment of our desired outcomes. So at the highest level, they're recognizing that a greater involvement of the community is really going to be the key to a sustainable treatment as prevention program in Zambia. They're also we're realizing that the community is foundational, and we wanted to reverse the trend from imposing treatment strategies on the community to really embedding treatment in the community. And that started with positive community messages about early treatment and treatment as prevention, and that remaining the best chance to changing community norms, stigma, and behavior. And also engaging community leadership from the very highest level to sustain the efforts that are necessary for treatment as prevention over decades. We looked at facility-based versus community-based care models, and we saw that through community-based care models we can have a lower cost workforce, we can do less laboratory, we can have a lower loss to follow-up with higher retention and care, a higher adherence, and improved utilization of facilities through referrals for care for the sick and complex patients, rather than using facilities as we currently are to take care of majority of healthy patients. The impact of our current facility-based model is that many patients are not tested for HIV, many patients do not complete the evaluation process, many patients are not initiated on ART before significant illness develops and therefore increasing deaths, and many patients drop out of the system due to the efforts needed to make the trips back to the clinics and maintain that incorporation into care over long periods of time. So we felt that the time was to change paradigms if we're going to make treatment as prevention really successful over the long run. And the idea was to start the process in the community and scale it up the healthcare system as necessary, restore stable patients on ART back into a community care model, and only persons needing specialized care remain in healthcare facilities, and thus we can also expand the community workforce and job creation. So community-driven HIV care model, care begins and mostly remains in the community. It starts with diagnostic testing, with rapid HIV testing, evaluation with community screening questionnaires, and renal testing. And although this isn't policy now, but what we're working towards is actually treatment initiation in the community based on negative screening and a completed adherence evaluation. Ongoing monitoring through monthly community visits for pill counts and screening questionnaires, and then to capture all that data electronically for evaluation. These community-based treatment workers would be persons in the community network that serve as a primary link for healthcare in the community. They would be responsible for a specific number of family units for HIV testing, evaluation, treatment initiation, and ongoing monitoring, and they'd have endorsement from community leaders. And they would have financial support from the national government as part of an equitable jobs creation program. Key to this would be an electronic medical record system that captures all this data so that we can follow logistics and everything else that's necessary for implementation. In Zambia, we use what's called a care card, that is a card that's scanned through a reader that tracks all the patient data and then can also be transmitted to another device for incorporation in the national system. And this EMRT would provide instructions on all procedures, educational and informational messages, questionnaires for screening and evaluation, algorithms for decision points, as well as pill count adherence tools, and record all this patient data and have the ability to transfer it to a larger system. Community workers will be trained to accomplish the following. They will use this EMRT system device, provide informational and educational messages from the EMRT in local languages, perform rapid HIV test, administer a 4-item health screening questionnaire, and perform urine renal screening test. They will also be able to follow algorithms for referrals of potentially ill people and complex people, and eventually we hope that they will be able to initiate ART in HIV persons with negative screenings. They'll be able to monitor monthly pill adherence with pill counts and provide refill medications, refer ill people in the community to a facility for advanced care, and then also accept referrals back into the community care model from healthcare facilities, and do this with communication and supervision from district facility leaders. The outcome of this program would be near universal HIV testing in the community, with only persons potentially ill or complex that are referred to healthcare facilities. Stable persons from healthcare facilities can return to the community. There's rare loss to follow-up, high adherence, decreased cost of care per patient, and decreased community stigma with increased employment in the community. The sustainable benefits would be the majority of HIV positive people are diagnosed, initiated on ART, and monitored in the community, with the majority of persons in HIV care and treatment may never require any facility-based lab work. Healthcare resources are invested in those who are truly ill rather than monitoring the healthy, and a rapid decline in new HIV infections, HIV-related morbidity and mortality, TB infections, and elimination of mother-to-child transmission. The questions we have to answer with this model is, are rapid tests, and we're looking at the feasibility of oral tests, feasible for community testing? Does a urine test, maybe a test even for microalbumin, screen adequately for renal disease? Does a 4-item questionnaire adequately screen persons at risk for serious illness? And are new HIV infections reduced with overall program cost savings, and do pill counts truly equate with viral suppression? The paradigm for HIV care and treatment in Sub-Saharan Africa has to change to really be sustainable and scalable, and the current paradigm is really failing to control new infections and leading rapidly down an unsustainable path. We really feel like only a radical new approach to HIV care and treatment that engages the community and slashes the cost per patient is truly scalable. The current path that we're following is to use the implementation of option B+ as an opportunity to explore models of community engagement that can be generalized to treatment as prevention, incorporate lessons learned from pop art, and then develop a national treatment as prevention plan that incorporates the community founded on evidence-based experience. Recently, last month, there was a Zambia Treatment as Prevention consultation meeting. It was sponsored by IAS, AIDS Healthcare Foundation, the Ministry of Health, and National AIDS Council in March. And Dr. Patrick Chikusu, the Deputy Minister of Health, stated treatment as prevention has been adopted as national policy. Now Zambia needs to resolve some of the challenges that may impede the TasP approach. It needs to step up test and treat programs. So there's a definite commitment within Zambia to move forward on this. It's just a matter of developing the right models that will fit the context we're